Welcome to this presentation on the global challenges posed for and by NCDs within our NCD online course, which is a little bit of a summary lecture drawing upon the different presentations and issues we explored the weeks before. Right at the beginning of this lecture, I would like to give due thanks and acknowledgements to both Professors Robert Beaglehole and Ruth Bonita, my former colleagues at WHO and now Emeritus Professors at the University of Auckland in New Zealand. Many of the slides I took from presentations they gave recently, and I was able to attend and discuss issues regarding the global challenges for NCDs with them. They're truly my mentors in this area. Now, the key messages in this presentation are the following: that NCDs pose a global crisis and we need to overcome the neglects. I would like to give you quickly again the UN context and WHO plans and strategies. Then emphasize that all those plans and strategies by themselves are not sufficient, but it always comes down to the implementation of policies. We talk briefly about national goals and targets which should feed into global goals, and highlight one issue which is very dear to Robert Beaglehole is about the accountability. And with that, we also speak about NCDs and the post-2015 development agenda. So as a summary or refresher, let's look at NCDs posing a global crisis. We know that those four key NCDs cause at least 2/3 of all mortality, and the important or eye-opening news for many is that 80% of those deaths occurring in low and middle income countries, and 50%, half of them, in women. Those facts need to be stated and restated to counteract certain myths about NCDs, that it would be a disease of the rich countries and only rich men dominantly would be affected or so. Now, the other important fact about NCDs is that about half of all NCDs deaths are premature. And premature, that's why it's so important, premature mortality is largely thought to be preventable. Another feature and reason why the focus is on those four key NCDs, heart disease and stroke, diabetes, cancer, and chronic respiratory diseases, is that they share a couple of key risk factors together. And posing a global crisis is the increasing recognition that certain risk factors, such as especially tobacco and alcohol abuse, but also obesity as a marker of physical inactivity and nutrition problems, are operating. Those risk factors have a global health dimension. Those are not only local problems, and certainly not only the problem of individuals, but there is a very significant global component to the spread of those risk factors, and therefore we need to address NCDs and their risk factors also at the global dimension. Robert Beaglehole is bringing forward 7 key challenges to this global development regarding NCDs. Number 1, he reminds us that we need to act in the context of global crisis, especially when thinking about influencing national policies to reduce the NCD burden. We have to be conscious of other concurrent, competing global crises, not only health crisis, but also the financial crisis, climate crisis, etc., etc. We need to build the case for action and overcome those myths I quickly highlighted before, and you might not be surprised, but you might have actually experienced yourself that those myths can sit in the heads of many, even policymakers, decision makers. We need to implement priority interventions. We come later to which one they are, but I highlighted already. To formulate is one step, but implementation is the other important step. We have now formulated, or the UN has formulated some commitments, but we need to hold governments to account. We need to support the WHO and countries in their plans, because certainly NCDs is not only a health issue, and therefore WHO would not be the agency to go around and fix it for other countries. Another huge challenge is that we should speak with one voice. We should avoid vertical programs, them versus us, infectious diseases versus NCDs, but we rather should explore more ways of integrating them. And last but not least, we always recognized, always meaning in our course, that NCDs pose a risk for development, and therefore we need to integrate and engage with the development discussions around the Millennium development goals, which are running out in 2015. And that's why I said before we need to look at the 2015, post-2015 agenda and the new Sustainable Development Goals. Now here an illustration. NCDs are embedded or linked, if you want, to the global crisis. And recognizing this, that NCDs are not an isolated health issue, we need to link them to the food and energy discussions, the global economy, issues of increased urbanization, demographic changes, social justice, inequalities, but also then, of course, we need to have political leadership to take on the challenge posed by NCDs. Now, the burden of NCDs, the 2010 latest global burden of disease statistics are projecting or estimating that about 35 million NCD deaths occurred in 2010. But as I said before, the important number out of that would be the number of premature death by NCD, and that is estimated as, if you look at the under 70 years, at about 14 million. And I said before, 80% of those ones occur in low and middle income countries. It was now labeled by The Economist the poor world's greatest health problem. And I think that's the World Economic Forum estimated the economic loss by 2030 at a staggering sum of 30.4 trillion US dollar. I'm saying that The Economist now labels it the poor world's greatest health problem because a couple of years ago, also The Economist thought NCDs are a problem of rich countries predominantly. So NCDs are a major cause of poverty, a barrier to economic development, and a serious threat to achievement of the Millennium Development Goals. If you subscribe to this statement, and I certainly do, this was issued in the third Lancet series about chronic disease, then you understand why our presentations, our lectures, our focus of NCDs is going beyond how to lower blood glucose levels or reduce waist circumference in obesity. We have to look at the causes behind the causes. We talked already about the priority interventions. What are those on a global population level where we know what health impact they have and can calculate the number of deaths averted? They were calculated and presented in a Lancet article in 2010, which I will make available to you. And they are around tobacco use, reduction of dietary salt, reduction on obesity, physical inactivity, and improvement of the diet, reduction of harmful alcohol intake, cardiovascular risk reduction in individuals at high risk. Those best buys were then, of course, also influencing the discussion about NCD targets and goals, which culminated in the UN high-level meeting in New York, September 2011, where countries and the UN and WHO formulated their commitments to establish multi-sectoral national plans to integrate NCDs into the development agenda across UN agencies, to set global and national targets, to measure them, and hopefully to increase resources available for NCD prevention and control. The global NCD goal, agreed then a year later at the World Health Assembly in Geneva, was 25 by 25, meaning a 25% reduction of the premature NCD mortality by the year 2025. Now that's the goal, and the targets, the criteria for choosing targets, which just came out a month ago, is that, of course, those which have a strong scientific basis should be chosen. They should be, of course, sensitive to change, but also realistically achievable in the time frame given from now to 2025. They should have a major impact on the global goal. As I showed before, we should have the evidence that there are cost-effective interventions available, and we should have baseline data and surveillance methods available to monitor the progress. These are the typical technical considerations which influenced the draft proposals and papers, which were then accepted by the World Health Assembly after a political consensus. So, as it is typical, quite often those might be conflicting streams in the discussion, and what the outcome is a mixture between technical considerations and political deliberations. Here are the set of nine voluntary global NCD targets formulated by the World Health Assembly and approved just a couple of weeks ago in May at their last meeting. At the top, the premature mortality reduction. The red bubbles highlights health system responses, and the blue ones are other targets addressing risk factors for NCDs, those shared risk factors. You can see those 9 targets and the 25 indicators around those targets in the documents I make available from the World Health Assembly. Now, these were formulated, suggested, and approved by the World Health Assembly, but you could also disagree or voice your satisfaction or disappointment. And Robert Beaglehole, together with us at the NCD Action Group, were a little bit astonished that the target for tobacco prevention is set at 30%, whereas we believe it should be set much more stringent. We have already the Framework Convention on Tobacco Control in place, which which needs to be implemented. I'm aware of about the difficulties, but enormous legway has been made. This is a UN convention, so we have the policy instruments not only at the UN level, but also at the number of countries who signed up to it. And one example would be coming from New Zealand, where they are fighting for a goal of becoming essentially smoke-free by 2025, and smoke-free means having a prevalence of less than 5%. Influence and participation of the industry in formulating NCD goals and NCD targets was very critically analyzed by Rob Moody and others, which then was published together with other articles in the fourth Lancet series on chronic diseases, saying that the food and beverage industry should have no role in the formulation of NCD policies. Of course, that also applies for the tobacco industry, but they focused on the food and beverage industry in this article. Also summarizing that public-private partnerships so far have done quite little to improve health, and we need seriously to look at regulations and market interventions to limit harm caused by food and beverage industry. And therefore I'm saying, as I said at the beginning, that we need to see NCD prevention and control also in the economic and other contexts, and not only in the medical arena. Now, Robert Beaglehole reminded also us to speak with one voice and to keep it simple. That is what, for instance, the NCD Alliance tries to do. Speaking with one voice, I'm not sure if they managed to keep it simple, and it is a great challenge because so far, before the lead up to the UN meeting, we had rather a more competing field of the different NCD entities, a very vocal diabetes association, vocal cancer associations, respiratory disease association, then the heart foundations and so on, rather placing themselves in competition to each other than to integrate and work together. That has changed, but there's still, of course, the danger of verticalization and also, of course, across infectious diseases. Whereas one should rather capitalize on the links with, for instance, the large programs around HIV/AIDS, links across chronic care needs, which are also there for tuberculosis, HIV/AIDS, malaria, and other infectious diseases. Explore links with women's and children's health, especially when it comes about disease NCD prevention and detection. A link to the life course approach and to universal health coverage. The NCD movement should also synergize its goals with poverty reductions, with the underlying determinants, with climate change, and strengthen in countries and globally the contribution of civil society organizations. A quick look at the discussion of the Millennium Development Goals. You remember that they were established at the Millennium to be achieved by 2015. Certainly progress was made in some areas, but not all. 3 of those goals are directly related to health issues. However, back then NCDs were not included, although we now can clearly demonstrate that they are undercutting achievements of certain MDGs. So in the post-2015 agenda, when it is about sustainable development goals, we believe that NCDs have to be in some form or other integrated and part of the new goals. What would we want in this post-2015 discussion? Certainly to be health included as a sustainable development goal. NCDs could be a health indicator, and especially Roberts and Ruth are encouraging us to examine what can we do. We can participate in that discussion through our national consultations, through open WHO consultations. There are other streams aside the UN stream in the lead up to the new development goals, and that is led by the G77 movements out of Rio, so we could contribute there and build our own working groups and lobby for integrating NCDs in the SDG discussion. So in conclusion, to prevent and control NCDs, rapid progress should be possible with existing evidence about cheap and effective interventions. We need an accountability for the formulated and existing now UN commitments. The accountability needs to stretch across UN, but also across the nations. We need for accountability goes along with monitoring, review, and revised or renewed action. NCDs, we argue, should be central to the post-2015 development agenda. Actually, I shouldn't say it should be central. They are central if we want to or not. If we don't integrate them explicitly, we might do so as to our own peril, because we saw from the development, from the epidemic, from the spread and distribution of NCDs across the world, they are already a global issue. And a key role in moving the NCD agenda forward should come also from civil society, which, in my opinion, hasn't had the tradition or the capacity so far developed like the civil society input and contribution and driver position we experience now in the HIV/AIDS movement. There's a lot still to be done. And with that, I'd like to close this presentation on the global challenges posed by NCDs and for controlling those NCDs.